and has been directing and orchestrating the entire development of this mission. Also with us are the joint directors, Mr. Kiran Gopal and Mr. Vikram Pagaria, who drive adoption of NDHM across India. So before we move on, we'd like to invite Additional CEO and Mission Director, Dr. Praveen Gedam, for his opening remarks. Sir.
Thank you very much. I hope I'm visible and audible. Yeah, am I?
Yes, sir.
Okay. So I welcome all the participants in this webinar, where we will be discussing the issues of data retention and the related matters in the health ecosystem. At the outset, I would like to make it clear that there is some lack of clarity about who should be the authority to get such guidelines issued. So we had approached the ministry with request that this may be issued, but then the NHA was asked to submit a draft of such policy or guideline. And therefore, we thought that before we submit such draft, we get the feedback from all the stakeholders who may be interested in this particular process, including other government organizations and departments. So that's the background in brief. So whatever we are discussing here is we are open for all types of suggestions, including that we should not have such policy, or we should have that policy, or particular department should issue such policy, or some other department. It should be left to the states, or it should be taken over by the center. All such questions are open, and we look forward to your comments. Second, I have observed in some of these consultation discussions that participants start asking questions. See, we will be responding certainly to the questions once the policy is formalized and responding to queries. At this moment, we don't have policy or guideline. So I suggest you should make interjections or give your comments with specific demands, like let us have this and let us have that, rather than how can we do this and how can we do that, right? So you can clearly say that this should be done by agency X, the classification should be like this, rather than asking what is contemplated in the classification of documents. There are many questions to be answered. Should we limit this to only digital health, or health as a whole? Or even within digital health, only ABDM compliant solutions and ABDM onboarded facilities, or the whole digital health spectrum? So there are many issues which we need to discuss. There are pros and cons of having classification of health records to extremely detailed level of granularity. So it gives a better picture, but then things become more and more cumbersome. So what is that golden mean between convenience and a good detailed classification? All these questions are open. So without further delay, I would request our team to start the presentation. Even when the presentation is going on, please keep typing your questions in the chat box. After that, we will take all the questions, and you can give as many suggestions as possible. There is no time limit as we have finalized. Please go ahead, Kiran and team. Thank you so much.
Right, thank you so much, sir, for the opening remarks and pointing out the complexity of developing such guidelines or policies. We'll of course treat this as a brainstorming session, and we hope to have many more ideas generated during this session. So everyone, good evening once again. The proposed health data retention guideline or policy was released as a consultation paper on 23rd November 2021. We request everyone to submit their comments, detailed comments, by 24th December 2021 on the APDM website. In today's webinar, we'll discuss the consultation paper in brief and will respond to any questions, queries, or comments you might have. But as ACO sir said, please do note that this is not a question and answer session. It's more a thought provoking session where we come up with, some good ideas on how we can move forward on such a guideline or policy. So in today's presentation, we'll begin with a brief introduction to ABDM, and then we'll cover the need, the relevance, and scope of the health data retention policy, both within the ABDM ecosystem as well as the larger healthcare ecosystem. We'll finally open up the floor for questions. Before handing over, just a few housekeeping rules, right? So we request all participants to remain muted. If you have any questions, you can type it in the chat box, or you could raise your hand. When we are responding to questions or queries, we are first going to focus on the questions in the chat box, and then we'll look at the people who have raised their hands, right? If your name is called out, please do unmute and you can ask your question. We, however, request all participants to keep their questions on topic. So thank you, everyone. We'd now like to invite the Joint Director, Mr. Kiran Gopal, to take us through the proposed health data retention policy. Over to you, sir.
Great. Thank you. So welcome, everyone. And first of all, I'd like to thank all of you for taking out time to participate in this consultative process. Because I think in order for us to come up with a policy that is inclusive and can address most of the issues, it is very much important that participation from a wide spectrum of stakeholders is extremely important. And I'm glad to see that quite a few of you have joined us today. So like Arun has said, I'll just take you through a brief journey of ABDM, the architecture itself, and then we'll then dive into the proposed policy itself. Okay, so how did the ABDM start in the first case? As you can see, the National Health Policy 2017, it actually advocated an extensive deployment of digital tools for improving the efficiency and service delivery in order for better outcomes in the health ecosystem. And this was topped up by the National Health Stack, which actually provided a vision for a digital stack for health, which laid out the basic objectives and principles on which one should be working. Finally, the National Digital Health Blueprint that was published in 2019 came up with the framework of how this digital health network is to be built. And this is the basis on which the National Digital Health Mission, now called the Ayushman Bharat Digital Mission, was started. So, and this consultation process has been going on since the very beginning. That is, since we've had the National Digital Blueprint, at the initial time when before releasing the blueprint itself. And then we had a second level of consultation before the launch of ABDM pilot in August 2020. And then we followed up with the third level consultation with specific stakeholders, which included insurance companies, government health programs, licensing authorities, medical councils, etc., who are like the major stakeholders in the entire health space. The current consultations, which is actually a series which we've been doing for quite some time now, it has been going on since we've started coming up with these various papers and information of the various digital building blocks that constitute the ABDM system that's going to be part of the overall digital health ecosystem that we intend to build. Next, please. So to begin with, what ABDM stands for, what are its basic principles? As you can see, there are two major parts to it, the functional side and the technology side. On the functional side, when we say educate and empower, we actually mean that implementing ABDM or the success of ABDM depends on how educated and empowered the end user, which is a citizen, is, and also What is the video? And also, you should start the video. Yes. And also, how the various service providers are using this system, and how we are able to empower them to do their services and they do their work in a better way. It is universal and inclusive. I mean, the basic building block of ABDM, that is the health ID. This is one thing that the government has decided will be available for every city, every person, every individual, free of cost. And in order to ensure that we cover even the remotest parts and where network is not available, we have options like assisted mode and also offline mode of creation. So that way we ensure that we are able to reach even the last mile. Think big, start small, scale fast. This is the agile methodology or that we are adopting throughout the the development process, and security by and privacy by design. So one of the chief or the important parts of the whole principle is that health data and personal data being sensitive, ensuring security and privacy is paramount in the implementation of this entire mission. And national portability and accountability go hand in hand, where we would like to make sure that people are able to access their health records by being in any part of the country, by visiting any part of the country, any hospital. And the data fiduciaries who are involved in using, processing, storing the data are held accountable. On the technology side, interoperability is the basic tenet on which ABDM is being built. The idea is to build a framework. This is not a software. This is not a system which you simply download and install. This is a backbone of what is going to be the digital highway for information processing or of data related to health. Federated architecture is another principle where we say that we do not store data in one single place. This is one thing that needs to be understood very clearly. And in fact, this is in fact one of the main reasons why this data retention policy also becomes important. The objective here is that whoever creates the data will be storing data locally, and that is made available to different players in the ecosystem. So the data is going to be distributed across the entire ecosystem, across various players, and therefore data retention becomes a very important part here. Single source of truth in order to remove all duplicacy, in order to ensure data consistency. The objective is to ensure that this remains a single source of truth. Open APIs are again another fundamental tenet to ABDM, where we say that our architecture is open, we use open source systems, and the idea is to publish APIs to which everyone can subscribe. And the design, like I said, is minimalist. We don't intend to overload the system with various features. We will have the basic structure on which various players are able to latch on to. And leveraging legacy is another key factor, where we do not say that we are going to kill anything existing. We are only going to enable that any existing player or system can be onboarded without any hassles. Next, please. So the architecture of ABDM can be briefly shown in the schematic that we are showing there, where we say the underlying thing that drives the success of this initiative is the JAM and other digital public goods that the country has created on account of the efforts taken up by government, which include things like Aadhaar, UPI, UPI e-voucher, which today is called e-rupee, e-sign, DigiLocker, and such, and consent artifact, which is in fact one of the major important part of the building blocks of ABDM. And this is leveraged by the health data exchange, which constitutes the basic the digital registries, which are the basic building blocks, which are the health ID, the healthcare professional registry, the health facilities registry, the upcoming drug registry, etc. And then the health information exchange is the medium through which different stakeholders will be able to talk to each other and exchange information. And then while we are building this, building standards is also an important part. And in fact, this webinar, part of this webinar is also under this particular head, we are talking about standards of data retention. Similarly, you have standards for claims, you have standards for various markup languages, etc. So that is another part. The health services interface is another layer envisioned for enabling digital services into which the user applications are going to plug in. I mean, this is an ongoing work. I mean, part of it is functional, and this is continuously being developed. And ultimately, the ABDM architecture will connect to other digital ecosystems in India to enable innovation and new modes of service delivery. So, like I said, this consultation mainly focuses on retention mechanism for all types of health records generated and shared across the ecosystem. Next, please. So now we get into the main subject of health data retention as to why we need a health data retention policy. As you can see, the current challenges are there's no standardization as such. And ABDM, since it envisages that multiple types of players are going to be part of the system, and if each one has their own standards of data retention or policy or guidelines, it becomes difficult to communicate with each other. And then lack of common guidelines across public and private sector players is also another issue. And then we do not currently have a very specific legislature at the national level pertaining to data privacy. While the work is on, and we all are aware of the work going on the PDP bill, but that needs to be that everybody is looking forward to it. But in the meanwhile, data retention becomes an important part. And as a result, lack of longitudinal health profiles throughout patient lifetime actually hamper evidence-based decision making and informed decision making. And this can go a long way in improving our health outcomes. So current mode of retention, as you can see, large facilities have specific medical records department with MR technicians, and large file formats of audio, video records, etc. is maintained by additional coding as per required by the Insurance Regulatory Development Authority, etc. So this is one of the issues. Next. Further going, you can see existing guidelines in India, patient health information is defined as sensitive data under the Information Technology Rules 2011, and the Ministry of Health and Family Welfare also notified EHR Standards 2016. But then, like I said, we need to have a very, very clear understanding of how these are going to affect data retention and what we need to adopt as part of the ABDM system itself. And critical aspects of detention are classification of health data itself, the retention duration, because the longer we try to store it, there is a greater chance of data breach or data loss or corruption of data, which hampers easy retrieval and usage. And classification of data becomes necessary because especially for critical health information, which in fact also includes our birth certificate, is also in fact an important part. So such information and any critical illness or any other such information becomes important, and therefore health data retention policy needs to address all these issues. Next. So the very first two major questions that we need to ask is whether there is a need for health data retention policy, and will Indian healthcare ecosystem benefit from such a universal data retention policy, and what should the key elements of this policy be? I mean, this is the very first question. We've tried to think about it among ourselves, but then the question is of course open to everyone now. So start thinking so that we get suggestions from you on this. And how should the guiding principle of this policy be determined for the benefit of stakeholders and ease of adoption by varying size of entities? I mean, this becomes very important because you can have a very, very big hospital chain, and you also can have a very, very small nursing home. And if we want to bring everybody onto this platform, these principles should be in such a way that they are easy to implement and follow even by the smallest of the players. So these are the two first initial questions. Next, please. So another thing that we need to consider is about the scope of this policy itself. So the first option is to make sure that they say that the entire healthcare ecosystem in India, including those who are not part of ABDM or who have opted out of ABDM. Remember, ABDM is a voluntary thing. People can opt in and opt out. So what if we take it for everybody in the health system? So the pros are that yes, there will be uniformity across, and then this will actually make it life simpler. Whether you are part of it or not part of it, even somebody opts out of it as an individual or as a health facility, it does not hamper their day-to-day activities. But at the same time, enforcement becomes a problem. We have seen laws and policies where enforcement challenges sometimes limit the benefits one can reap out of such policies, and therefore one should be careful before making a policy that one cannot enforce. So that's another part that we need to consider. The other option is to say that all healthcare entities who are opting in to be part of ABDM shall comply with these data retention guidelines or policies that will come out. So here again, the scope is simpler because we are already talking about players who are willing to be part of ABDM. So in a way, they are ready to go through this process, and it's relatively easier to attempt. But then the cons are that you will create systems and subsystems where part of it is applicable, part of it is not applicable. Imagine a very, very large hospital system where part of it is on ABDM and part of it is not. We do not know if such a case may arise, but what if it arises? Then what would happen in that case? And then, of course, what happens to those who opt out of ABDM? You are part of ABDM today, tomorrow you are not, then what happens? So this is another aspect that that comes in when we say that it applies to only those who are opting in for ABDM. So these are two options and the pros and cons that we've tried to list here. There may be more, and we would like to hear more from you on this. Next. So going ahead, the questions that we try to frame here are as per option 1, the proposal that the policy will be applicable to all healthcare entities from health data retention perspective. And as per option 2, it will be only to ABDM participants. So now what do you think would be better? Second is, how should such a policy be implemented given limitations in terms of infrastructure, capability, and sufficient understanding of health data in the healthcare ecosystem? I mean, this also becomes a very crucial question, because we all know that understanding about data, the data retention policy, the techniques, and even the costs involved in data retention. So let's say if I'm a small clinic, and if I were to nursing home, and if I were to store data perpetually or for multiple years, I have to either have something of my own where I store the data, or engage a data fiduciary to do it for me. So that becomes one of the limitations. So how would this play out in such a case? So the another question is, as ABDM has a provision for opting out, like I already said, multiple scenarios will be possible. You are in, you are out, then again you want to come in, then what happens in between? What if you do not follow it? And if you go for option 2, you are in, you follow it, you go out, you don't follow it, then again you want to come in, then what happens to the data that has been created in between? So these are some of the questions that arise from this option 1 and 2. Next, please. So the proposed policy, we tried to consider some critical elements for data retention. And the very important part itself is the duration of retention. The whole idea is how long we need to keep this health data. And like I mentioned earlier, there is not complete clarity. There is no complete clarity and defined guidelines on duration of health record retention. This is varying across geographies, and varying across cases, and varying across types of data. So how do we synchronize all of these? A minimum 3-year retention period is adopted for personal data at multiple healthcare providers in India. So this is, I think, also part of the Clinical Establishment Act that has been adopted by some of the states. And for specific purposes, health records are retained for longer. I mean, certain medical legal cases or some terminal illness cases, etc. They are. And the retention requirements under ABDM may lead to, the idea is that we say okay, if you are coming under ABDM, let's say we prescribe a minimum amount of time, at least that you follow, and above and beyond, it is up to the participating entity and other requirements as and when they arise. And then a classification based retention schedule is one thing that we are trying to come up, because unless we are clear about what data to classify for how long, I mean, somebody gets a mild fever, we don't know how long that would be required, but somebody has a major ailment that probably need to be stored for long. So these are the things that we might have to consider. And then storage and maintenance becomes another important aspect. Like I mentioned earlier, the whole objective is to go digital. And once we talk about going digital, then this whole thing about what is the mode of storage. As of now, we all know that electronic, physical, and original forms of health data are stored. In fact, some paper data is actually scanned and stored. We have talked and we have come across multiple cases where there are private applications which are actually helping people scan their prescriptions, records, etc., and store them. So there are such solutions already existing. So, but then once it becomes a huge amount of data and once it starts piling up, one need to decide what is the best way to store. Then maintenance and exchange of health data is again an important part, where unless we prescribe specific standards of storing data and encrypting them, the whole idea of privacy and security becomes a challenge. So standards for that also becomes an important part. Next, please. So as of today, we observe that in general, this is a very, very general classification that one has observed. So we generally see that data is classified into these three major types: outpatient, inpatient, and a special category, which includes mental records, genetic records, donor records, and other variables. I mean, these days we all wear a Fitbit or a smartphone, a smartwatch, and that tracks a lot of information. So these are the three different major types of data that we generally have seen. Next. So now the questions for consultation that arise from here are mainly these: that should a blanket detention duration be adopted for all health records in India, or different schedules be defined as per a classification? What is a better approach? Obviously, one is a very simple one shot approach, but it doesn't make sense sometimes to store data for long, and sometimes at that date that duration may be too short for some kind of information. Now, how granular should the data classification be? Should we really go deeper into classifying data, into saying that acha OPD may, do we say that do we classify it into what the doctor writes on a day-to-day basis as to seen patient continue the same treatment, or what the nurse administers to the patient depending on what the doctor has said? And then afterwards, the follow-up that happens, I mean, how deeply do we go while classifying this data? And there are, of course, again, pros and cons of going as granular by going. So basically, is more granularity required beyond that presented in the sections above, or would it suffice to just go for, let's say, an OPD and an IPD kind of classification? And then we would also like to listen to your views on how a detailed granular data classification will enable better health data retention. And also we would like you to hear your suggestions on classification of health record types as proposed, or if any other further granularity is required. And then what should be the ideal duration of retention? Of course, all of us, there's one very important thing that we need to consider, that this has been happening across the world. There are certain standards, mostly in developed countries. So do we adopt them? Do we follow them? Or should we tweak them for our Indian conditions? So that's what we'd like to hear from you. Next, please. Then another question is, while we propose that all entities opting to join NDHM, the National Digital Health Ecosystem must be able to retain health data in electronic format, and other entities of healthcare ecosystem may consider physical or original formats. So what options should be made allowable as part of the policy being proposed? I mean, if everybody goes digital, nothing like it. But then we know that there's a time that takes. There's a lot of infrastructure that we build. There's a lot of training that needs to happen. Given that, how do we make this operational? So health data records can only be digital, only be physical, or a combination of both in any hospital. So accordingly, the question arises whether all the above considerations should fall under one policy or under separate or independent policies. Then there is like another question which says, should there be a provision for extension of duration or retention of health data under the policy being proposed? And what considerations should be made in defining these guidelines, allowing for such an extension? Then obviously this whole authority, who is the authority who will decide, comes into question, who says who shall have the apex authority to oversee and implement health data retention? Is it the National Health Authority? Is it the Ministry of Health and Family Welfare? Is it the individual state governments? Who should it be? And at a macro level, who should really be rolling out this policy? Should NHA make it and give it to states and ask them to roll it out? Should NHA issue it? We should issue it ourselves, or should it be issued by some other entity? Is another question. And then, like I said earlier, how smaller clinics or centers, both public and private, build the capability in a timely and cost-efficient manner to take responsibility of data retention for long time periods. What also is important here is this whole data retention in a small setting becomes very, very challenging and becomes daunting. And this should not become a deterrent for people to come on to this platform. That is also one of the objectives. And then finally, how do we ensure business continuity in such an environment? And how, so that the platform can provide the service that it envisages to all the players. Next. So we come to the proposal now. By what the paper proposes, we've already shared it with you. Some of you, I'm sure, must have gone through it. Some of you, for the benefit of everyone. So we intend to propose, intend to classify data into mainly these 4 broad cases, that is inpatient, outpatient, deceased patient, and exceptional cases. And the mode of health data retention, we intend to say that we would recommend that all health data should be retained in electronic format. I mean, this does not mean that everybody should be typing in a computer straight away. Even if you were to do it on paper, if you can digitize that record and then save it, that also is something that we would encourage for some time at least. Electronics formats will be preferred for all entities opting in to be part of ABDM. This is something that becomes important, because unless you are onto that electronic mode, you will not be able to take full advantage of the ABDM ecosystem. Then electronic, physical, or original form of retention should be acceptable for data retention for option 1. That is for everybody when we come in. So like I said, you could have physical data, but then do you scan it, put it on a warehouse so that it is accessible? So how do we go about it? Then proposed data health governance structure, we propose that we will have a data protection officer who will be responsible for compliance related to data retention for all covered entities. I mean, anybody who is part of the ABDM ecosystem, we would say that the data protection officer would be responsible and would have the authority to ensure that all these players are complying with the guidelines that come out finally. And the data protection officer may be also responsible for conducting an audit or in order to avoid orphanization of data in cases where a HIP or HIU, that is a health information provider or a health information user, no longer exists. I mean, a simple case is when there is a hospital and then it is closed. What happens to the data that it has stored so far? Would that data be lost forever? But then as a patient, it's a loss to me. So how would we go about such cases? So once the guidelines on policy and data retention are released and made into effect, ABDM would like to emphasize that under no circumstances it shall have an overriding effect on any existing guidelines. I mean, any rules or laws that come in, we would not existing laws or guidelines mentioned and any other applicable law of the land. We would try to be under the ambit of the legal structure. That is how we would be functioning. Next, please. So in terms of the retention period, this is what we propose. We say that for inpatient data, 10 years after the last entry or encounter should be the duration of retention. And in case of a minor patient, this type of record could be maintained until patient turns 18 or 10 years, whichever is later, because after 18 he becomes an adult and then the whole consent thing comes into picture. Outpatient, 10 years after the last entry or encounter. And for a deceased patient, again, we propose 10 years. And for exceptions, such as medical legal cases, immunization records, clinical trials, birth and death register, we say this record is to be maintained forever. So this is what we have proposed in our guidelines. And obviously, we'd like to hear more from you. So the questions are next, please. The questions arising from the previous few slides is that what should be the governance model for health data management policy? I mean, will a governance model for health data management policy be sufficient for retention policy, or should there be additional structures? And how will the policy regulation be enforced? And what should be the structure across relevant entities responsible for retaining health data? I mean, this is a very, very open question, and we would really like to hear from you on this. How should the implementation of the policy be done in case the policy is made applicable beyond the ecosystem of ABDM? This is another major question. That means that we are going universal and saying that everybody follows this. So in that case, how do we implement it? And then, I mean, is there any alternative model? I mean, is there anything you think we have completely missed out, or any other different approach we should consider? And we are absolutely open for that kind of discussion also. So overall, I would sum up saying that data retention is an extremely important part of our overall digital health ecosystem that we intend to build. And in order to achieve the objectives, facilitate the interoperability that we promise, and ensure that entities are talking to each other and data is flowing seamlessly, this data retention becomes an important part. And your suggestions, I mean, your observations and comments during this consultation process will go a long way in refining this. And we truly want to make this a public consultative process where we try to take in as many suggestions and comments that you have in order to make this policy or guidelines as robust as possible. So I think with this, I will close the presentation. And Arun, you can take over now. And I see some participants have already raised their hands. And Arun, please take over.
Thank you so much, sir, for the kind presentation. I think we've seen quite a few questions or ideas being shared on the chat, and some of our moderators have been responding to these questions. What I'll do is just have a look at all the questions and queries and suggestions which have come up, and post looking at the discussion on chat, we'll call out people who have raised their hands and they can ask their questions. Again, my humble request to all participants is to be very clear and focused on what we are discussing right now. I do see some chats which are, out of context. So let me just go back and get the chat. There are, a few interesting suggestions here. So there are some questions on coding standards and whether there will be a reference point. Thank you for that, Mr. Ranganathan. What we do feel over there is that coding standards and data retention should be treated separately. Coding standards could be mandated at a later point of time. But with respect to data retention, right now we are not as focused on the coding standards as much as we are on the data retention policy per se. Some questions on whether EHR standards are binding. I think that has already been responded to. Saurav's shared quite a few points, which includes some areas of thought, such as what should the data be like? How should it be stored? Uh, where is it going to be stored? And is it going to be on private or public stores, etc.? Yes, these are, things which we are thinking of. And we are working towards these. These are extremely interesting suggestions. My request to you, sir, would be to elaborate on this and share your inputs on the feedback page which is shared. Uh, there are some suggestions from Mr. Ranganathan again on the utilization of data retention. Yes, we do understand that we'll be able to make a lot of decisions based on the data available. So great so far. Mr. Ranganathan has also spoken about some sort of an online sanitization layer. I think this is interesting, and we want to understand more. Mr. Ranganathan, if we could just unmute him and we could ask him for his inputs, that would be great. Kanwadeep and team, can you please unmute Mr. Ranganathan?
Hi, good evening all. This is Araman Ranganathan here. The thing regarding the sanitization layer is what I had come across during other hospital interactions. Like some of the data that is coming up, initially we take it for some of the scans, etc., or other information. We preliminarily have some observations around it, but later on, it becomes very important that that data needs to be maintained for a long time for reference points, and you'll be able to make a lot of decisions based on that. So certain set of data directly you can retain it in the underlying layer, in something like Hadoop or something like that, which can be high volume. And from there, you have a sanitized data or the meta information that alone can be, sent through AI pipelines. Anyway, AI also is one thing and data science also is another thing. We can sort it out and keep a data set separately. Especially CT scans will be taken normally, but some cases will lead to a bigger reference, and the doctors will be able to diagnose more on that the more they have that reference points. And all the AI reference engines also use the same pipelines. So the basic thing where I'm coming from is, if we can retain maximum data, have data sets classified based on AI engine references, and keep it as separate inference points, that would help in, so that layer can be open sourced. Whatever algorithms you earn, more number of people can also use those algorithms there, and it will help us in providing a better healthcare to the last mile till primary healthcare, right? That's the interest.
So, okay, as I understand, basically you're talking about utilizing the data that is already stored for, let's say, some kind of research or learning and that kind of activities.
Exactly.
Right? Okay.
Yes.
In fact, there is also a part of this whole retention that that is also worth discussing. Is also about destroying and sharing and storing data in certain formats. I mean, when we say you store it for 10 years, after what happens after that? Do you delete it entirely so that you can't retrieve it? Or do you anonymize it so that it just can't be linked to the original user in some way? Or you pseudonymize it that so that you hide certain tasks and you can, let's say, have an internal mapping so that you can retrieve the data if required and map it with the original user if necessary. So this is very important, and your suggestions, Mr. I'm sorry, Ramanujan?
Aravamudan.
Aravamudan. I'm sorry. Are very welcome, and we'll definitely have a look at it. And this is actually very important for us also.
Thank you.
Yeah.
Thank you so much. Mr. Prabhakar Kundurti has specified that medical notes and prescriptions along with prognosis data needs to be on a long-term retention, which is different. And he's also mentioned that there's a different retention period based on longevity versus new technologies emerging. Sir, could you throw some light on that? Could we please unmute Mr. Prabhakar Kunduti, please?
Hello.
Yes, sir, we can hear you.
Yeah, thanks for the opportunity. Actually, when we're looking at the data of a patient over a longitude of time, there are different kind of categories which you have already classified, like inpatient, outpatient, and special cases, things like that. These are all interesting. But the main thing what happens, according to at least my experience, is that most of this data, which is retained for a longer time, it is not mineable. It is not what you call accessible for doing research. So I was thinking that the ideal way would be to look at technologies which are emerging, which sometimes make that particular data obsolete or maybe not useful at all, because research proves something else, either drug research or clinical research. So how do you categorize that in terms of longevity of each data sets? That's what my question came from.
Understood, sir. Thank you so much for that.
No, Prabhakar ji, I mean, could you please elaborate a little bit? I mean, to be very honest, we couldn't follow what you just said.
So one simple example, sir. Suppose there is a particular clinical path for doing a work on hepatitis B. And say over a period of time, research has proven that that particular clinical path is not valid, or that particular data set is not valid. How do you recognize that and put in which category you're going to put for its longevity? Like how long or what benchmark is there for you to tell this 10 year is not good for it, or maybe 50 years is good for it, or maybe 5 years is good for it? How do we do that?
Okay. I think one thing that we need to clarify here is we are specifically talking about the technology part and storing the data part. I mean, we are not committing ourselves to giving an additional classification to data as to saying that what is relevant today and what is not relevant today. I mean, this data would be there as per the data retention timelines that have been decided for a particular type of data. And whether that data is to be used for clinical research or whether that is useful or whether that information is currently, useful for any other purpose is a decision that needs to be taken separately. I mean, this doesn't form part of the data retention guideline or policy itself.
No, I fully appreciate that, sir. My point is, how do you keep this data available for retention? Like, I mean, is there any time for that under a special category you put it or under what? So there may be people somewhere in the world who want to do that kind of work. Say for in India, they want to study something on, say, genetic diseases, or they want to study on diabetes. So if you tell that this retention is only for 10 years, we may miss out a big scenario there.
Okay. I think then this comes into this category where we like what I discussed is like what happens after 10 years. Do you delete it? Do you anonymize it? Do you pseudonymize it? Going ahead, data is very, very valuable, and we all know that once stored, it is. I mean, the data that is there, it can be anonymized and it can be kept in a way that the data principal can never be identified through it, and it could be used only for research purposes. This is a very good suggestion. We'll keep this in mind.
Thank you, sir.
Thank you so much. As the Joint Director pointed out, we are focused primarily on the retention policy for now. And the archival issues are going to be, captured in another set of guidelines or policies. But these are important things for us to think about on the longer term. So Dr. Naresh Agarwal talks about having electronic discharge summaries generated at source. Prabhakar sir talks about, the source digitization to capture all the potential for clinical research, which I guess he's covered in his question and suggestions.
Arun, if I may intervene?
Yes, sir.
There was one comment I was looking at, which I think clarifies one basic issue here. The question was whether this policy is applicable for data stored in facility or is it applicable to data that personnel or an individual controls. So let us understand this. Let's say a person goes to a hospital or a health facility, whatever data that is created upon him, it is stored in that facility in the data repository of the facility. The individual can access this data through what we call the PHR application, the personal health or health records application. So let's say there is a particular health record that the individual has, let's say, downloaded it onto his smartphone and he stores it. And that data record is also available with the facility. So these guidelines are about the data record that is available with the facility and how it has to deal with it. Otherwise, as long as an individual's personal health data is considered, he is free to keep it until eternity. So these guidelines are basically for storage and retrieval, storage and maintenance of data by these entities, the data fiduciaries that are involved in storage, processing, and other management of data. If that clarifies, because this was a very basic question, I thought I should answer this. Arun, please go ahead.
Thank you, sir. Right. So just a couple more questions. One second. I'm just scrolling through. Apologies. So, okay. So, Sai Charan talks about, studying various country models as a US data healthcare retention policy. We've actually covered that. And, I think we've discussed how they are structured in this presentation today. But yes, we are, of course, going to be looking at various other countries as well. Mr. Pramod is suggesting that we look at opinions from medico-legal perspective. Yes, of course, sir, we will do that. This is an interesting question from Swapnil. He's asking, who is going to develop the infrastructure for data retention at a local level? So do you have any inputs there?
Okay. Like I said during the course of presentation, the data is to be stored at the facility level itself, that is at the local level itself. So two scenarios arise where the local facility has the capability to store the data by itself. That is, it has its own IT center or has a tie-up with some cloud service provider where, because this is not the core competency of, let's say, a hospital or a facility, we envisage that in the future, there will be data fiduciaries who are ready to provide this service. I mean, let's say I'm a small nursing home somewhere and I have patients coming in regularly and I need to store this data, but I don't want to get into the hassles of maintaining the servers and a data center, etc. I simply subscribe to this service. And in fact, there are things like DigiLockers, etc., who are also part of this whole effort. So the idea is that the infrastructure to develop, to ensure or maintain this data is to be done by the facility, which they are actually doing by themselves, by the way, today. Your records, your health records are actually being stored by them in physical format or in some cases in digital format in the premises or somewhere by the facilities themselves. That is what we keep saying. We will not change anything that is currently going on drastically. We will only say that digital is a better way to go. And we would say that would be the best way because retrieval and archival and usage, search, etc., becomes easier. Arun.
Yes, sir. So Swapnil, do you have any follow-up questions to this? Can we unmute Swapnil, please?
He seems to have left, but I think the question was important and relevant, and it benefits all of us.
Yes, sir, absolutely. This is very interesting. Again, Dr. Santosh Indraksha, he talks about relooking at the classification of data as inpatient and outpatient, because outpatient turns inpatient and vice versa. Sir, what are your thoughts on this? Dr. Santosh, if we could unmute him, please.
Sir, thank you so much for giving me this opportunity. and I was very keenly listening to the presentation made by sir. And I was wondering actually the classification of data point. The classification talks about the inpatient, outpatient, and then sometimes it is as a special conditions. Sir, the entire exercise of this data retention policy, I believe, is that it will assist in the uh, accurately diagnosing and treating the patient. So I think that is the main objective of this data retention, because if a patient is getting diagnosed at somewhere, and say for example in rural India, and he again because of the less infrastructure he travels to a metro city or maybe to the AIMS or something like that, then the national the data archival library, or so called, it will help the doctor to understand his last 10 years or maybe 5 years or so, what exactly happened with the patient and what treatment he has been given, and how exactly the disease has been made its course, how treatment has benefited. So the classification of data, actually inpatient, outpatient, it is vice versa. Sometimes he becomes inpatient, and then sometimes he becomes outpatient, then he becomes inpatient. So just merely classification on these 2 points, maybe, sir, looked out with a different perspective, like we may assign a universal health ID to a person, say for example, and the data for that person will be maintained for 10 years or so.
Okay, that's again a very great question. See, the thing is, that is exactly the reason why we said we will store data for both the categories up to 10 years. So, and irrespective of whether you are an inpatient or an outpatient, you would effectively have all your data, both outpatient and inpatient, all related data for at least the last 10 years. So whether one comes in as an outpatient and then has to get admitted and gets converted into an inpatient, that all that data would be tagged to his unique health ID, and that would be the loan identifier through which this data will be available. So I mean, like whether the data is stored classified as an outpatient or an inpatient, effectively we are going to store his data against the individual's health ID. So I think it will always be available for retrieval. Like I said, at any given point in time, if we go by the current guidelines and the current duration that we have just discussed, at least the last 10 years data of both inpatient and outpatient history will be available. Does that answer your question?
Yes, sir, it answers my question, but again I'm wondering, how does it add value by bifurcating into two different classes? So
exactly, the reason is, just imagine another scenario. Had I said I will store in our OPD data only for 5 years because they are not very serious cases, and in IPD data for more than for up to 10 years, then you think there will be a difference, right?
no, my suggestion is like the data for 10 years has to be stored against UHID. So
exactly, yes. See, ultimately the data that is being stored at the facility level will always be stored against a UHID only. That is a given. Otherwise, though, we will never be able to retrieve a particular individual's record. If that is the doubt, then it's absolutely very, very clear that health ID is the single identifier to which all data will be tagged.
okay, thank you, sir.
Right.
If I may, sir, I think the question relates to why do we even need the classification of inpatient and outpatient? Maybe we could look at classification in a different way. Is that something which you wanted to say, sir, Dr. Santosh?
Yes, sir. My anticipation was to have why classification is necessary when we have a universal ID itself. then how does it add value to the data classification?
Sure. Is there a particular form of classification which you would suggest, which would be more meaningful?
Maybe we can categorize some diseases, like if you wanted to have some metrics on the cancer or maybe diabetes or something, that can be jotted down, and such data can be pulled on.
Dr. Santosh, I'm sorry if I did not understand your question earlier, but that's a very, very valid point you mentioned. But then if you just go back to what we were discussing a little while ago, this is about granularity. So how granular would you like your classification to be? Should I start classifying based on diseases, or should I start classifying based on consultation type? So it is a decision, and we will definitely take your suggestion into consideration and see what would be the best possible way to go about. But thank you for guiding us on that line of discussion also.
Thank you, sir. Thank you so much.
Yeah, just some thoughts from my end as well. It's interesting that, when we focus on classification in the form of the consultation, whether it's inpatient or outpatient, it affects different players in the ecosystem differently, because there are multiple small clinics which are actually not digitized versus large hospitals and, even smaller medium hospitals, which are largely digitized. Almost 80-85% of hospitals are digitized in some way. So it does affect, the way in which people will start retaining the data and records. Till now, we've really not spoken about, how the data is being retained. Is it online and offline? Are we allowing, non-ABDM players to also participate in this? Is this policy going to cover them as well? I think that's a very critical question to be examined. I've not come across anything so far, but maybe we will cover that soon. Um, so a couple of other, messages which came in was about integration of ICMR for clinical trials and, anonymization of data. Sure, these are important aspects, but they don't directly relate to the topic which we are discussing right now. But of course, these are covered in various other consultations. Now, Rishabh wants to check if the data sets, which data sets would this policy be applicable to? So what exactly is going to be retained? So will it only apply to the health records of which are retained by the service provider, or health records which are under the control of the patient or individual? Kiran sir?
No, I think this is what I addressed earlier.
Yeah. So just another thing which I would like to add here is, whenever we talk about health records, the ownership always lies with the patient or the individual. So it's always under his control or her control. So moving on, Mahesh Radhakrishnan asks how we propose to harmonize the health data policy with the proposed PDP bill. Kiran,
yes, a very relevant question. During the presentation, I emphasized the fact that the data retention policy or the guidelines that will come out will be in compliance of all legal mandates of the government of India, and will be in will be guided by all the laws and acts of the land. So there is no question of any deviance or divergence from the same.
Thank you, sir. This is interesting. Pragya asks about why we are not considering a separate category for minors versus or intellectually disabled individuals. Do we categorize people in that way? So can we do a patient-based data classification?
That is also one approach that one can use. But like you see, when we say special cases, we try to capture the case of a differently or a differently abled person or that kind of information. And with children, I think the perfect example is birth certificate, the birth registration data. So this is data about minor children, their vaccination or immunization records. This is also records of in children. This is what we put under the special category, and this is how we are planning to thinking of dealing with. But if you have any specific suggestions on how it could be done or what classifications you think you have, I mean, could make this more comprehensive, please share it with us, and we will definitely try to see how we can incorporate them in our overall classification.
Thank you, sir. So the response to everyone on the classification is, yes, we are open to looking at new categories of classification. So if you have certain things in mind and how they would be useful to us, please do visit the ABDM website Consultation and share your comments over there. We look forward to your comments. Okay, so moving on. Okay, so Pramod has an idea. His suggestion is that the cost of storage has dramatically reduced. Probably look at 20 years. Pramod, can you just elaborate on this?
Can you hear me?
Yes, we can hear you now.
Yeah, so the reason I brought this up was because I think assuming that there is a careful look at the categorization that will be looked into. Now, the reason I bring this up is, I have to be frank, having experienced a period of time in the US and seeing what are the sort of cases that really, in the US, there's a very high level of medical legal sort of issues that keep going to court. Now, the only reason I'm saying that is because it kind of points to, which are the type of cases, which are the type of sort of classification or classified cases that are likely to, bring up issues even after, say, 10 years. And what you notice is many of them are things to do with, for example, delivery, child delivery and birth issues. The obstetric gynec are the most sued in the US. Then also new interventions being tried. The thalidomide case was a very classic example. Now, what happens is that with things like new drugs and stuff like that, the repercussions or the side effects may show up only after 10 years, right? There are possibilities. A classic example, we don't know what COVID, the treatments for COVID would do, or the vaccinations will do after 5 years, 10 years, and so on. So for certain, I think when you do the actual classification with some, pragmatic actual and reality of what should be probably stored a little longer than others, then the fact remains that storage is going to just keep dropping. I mean, if you look at what 1 GB cost us 10 years back to what 1 GB costs us now, it's such a drastic reduction in cost. Assuming that we are going to push that most do electronic storage, whether in digital or whatever in scan form or somehow, and second that the possibilities of storage can definitely be extended, or the cost of it can really be coming down for sure. I think in another 5 years it'll be even more drastic. So looking at that, maybe we can consider that at least those that have been classified as sensitive information, which may raise its heads after 10 years, should probably be stored a little longer. Second thing about imaging, I agree, imaging files are very large, but it doesn't mean that you cannot keep the impression of that imaging file that radiologists have given, which is a really important, starting point of the whole. So these are some suggestions which I would like to, bring up and suggest. Thank you.
Pramod, I'm happy that you raised this question, and in fact, thank you for raising this. We completely agree. The data rates are the storage rates are really coming down, and it should not be, a major challenge to store data for longer. And yes, why 10 and why only 20? Why not 100? I mean, we could even think of storing data for a very long time by making sure that it is appropriately anonymized, so that it may not be later on used for any other purpose. So I completely agree. And the duration is one very important aspect of storage. The 10 years was indicative and definitely not final. And in fact, positive thinking like yours and messages like yours and support from citizens and stakeholders like yours will always be more helpful in taking this even forward. And yes, 10 nahi to 20, 20 sahi, 20 to nahi to 50 sahi. We can definitely take it up further. So we will take a call on this, and we will definitely discuss this among the team here. Thank you.
Thank you, Pramod. I will request you to also visit the website and share your inputs over there. These are important ones. While we will be able to capture some of your inputs on the chat, it would still be great if you could, help us out by sharing more inputs on the website. Thank you once again. Mahesh has an interesting question. Mahesh Radhakrishnan, I'll request him to be unmuted. What he talks about is there some consent which is going to be provided by the citizen for how long this data can be stored? Right. So some citizens might want to keep it for 1 year, but others might not want it. So are we taking the consent for this?
See, the thing is, the whole idea about how individual data is going to be handled is will be guided by the privacy aspects and the security aspects of it. And there are two parts to this question. One is, would storing some data about a particular health incident, of course, it would always be related to a particular individual, would it be worth it to store it forever? Or should it be deleted once, let's say, the individual decides to opt out? And in fact, I was looking at one of the comments and somebody was talking about option to what you call pull out of it, or what you call option to be forgotten. See, there are two aspects to it. Whether let's say the current issue that is going on, there is this thing, the COVID pandemic that is going on. What would one say? Do we store the information that these were the COVID cases and this is how it went on, and or we delete it immediately after we tackle COVID, and let's say a couple of years down the line we are through with it? And should an individual's decision decide whether the data should be stored or deleted completely? I think, in my opinion, there are parts of data that are part of the larger public health question, and storage or destruction of that data can be decided by taking a balanced view of the both. But what will be definitely ensured or will be taken care of is the privacy of that individual. The details of the individual shall never be made, will never be made out. So this way, it actually, as let's say we all talk about the swine is what is the Spanish flu that came like 100 years ago. We know of it only because it was recorded somewhere. We know because of it only it was recorded, but we don't know who exactly got it. We are not even interested in knowing that who exactly got it. But we require some information to. This is like the knowledge that the human race collects over a period of time, and whatever is part of that kind of knowledge, I think will have to be part of this data, but definitely not anything related to private data. I mean, anything that compromises privacy or anything that exposes or goes against the whole privacy idea will definitely not be stored or will definitely not be retained. But anything that becomes knowledge, that is something that will be that would have to be kept. And this is a balanced view will be taken on this.
Mr. Mahesh, have we missed out anything, or did you have anything else to share here?
Hello, is I audible?
Yes, sir, you're audible.
Yeah. Sir, this one issue I'll just give my background so that the question can have a more clarity. So I'm basically from insurance space, and one of the issues which is there is relating to twin issues rather. One is relating to non-availability of data, and some of the people don't like to have their data made available to the insurance company, or particularly prior to the policy inception. So that is one issue we face. The second is also some of the aspects where people don't want to also give the detailed data of their treatment and other protocols or their health condition. So this is one issue which is there, and also coupled with the fact that some of the hospitals also find it very difficult to maintain some of the data. So these are the three issues which we have. From that perspective, and also looking at the proposed privacy bill which is coming, where an option is being given to people to remain, keep certain data confidential. I think this issue becomes very critical and will be an important aspect. So one of the aspect which we can think of is how we can make some basic minimum standards, as a recommendation. I know it cannot be mandated, but as a recommendation, and if you can build it in the proposed policy, it will be quite helpful. So both for hospitals as well as for individuals, so that at least some base minimum data are made available to various factors, because over a period, this will benefit the industry, the country, and everyone who are in the ecosystem. So that's a suggestion.
Okay. Mahesh, I think one thing we need to be clear about the current discussion is what we are talking about is about data retention at wherever this data is being created, and how to store it and for how long, and how to classify the data. Your question is absolutely relevant and very important. But I would say it is actually should be part of another discussion as to how the data should be shared among different players in the health ecosystem. And
Yeah.
and we will of course be having these discussions during other consultations, and I think it would be more useful if we take up this discussion over there. Because what happens is we'll completely digress from the current discussion, and we may not be able to take a final call on that. But
No, fair
I completely
enough.
agree. I completely
fair
agree. Yeah.
Yeah.
Okay.
Yeah, fair enough. But this is just one thought which I just, maybe it might
Fair.
have some impact over here. But
Yes,
I
yes.
understand the bigger issue is it needs a different forum for discussion, not
Yes.
here fully. Yeah. Thank you, sir.
That's fair. Thank you.
Yeah, absolutely. So to summarize, here we are talking only about retention of the data, storage, sharing the data post, storage is a different thing, which we will cover as a part of our consent framework. We've in fact had a couple of stakeholder conversations here previously. You could please visit the ABDM website and learn more. Great. So moving on, some suggestions on data which are valuable for research to be kept for a longer time. Some other data to be stored, for example, data from wearables, or some digital information of regular investigation. I'm not absolutely certain about this though. Mr. Kedarnath, can you specify what exactly you're talking about here? Kedarnath Kamwar.
Kedarnath ji, kya hum are you able to hear us? Could be some issue.
Yeah, we'll move on.
Arun, maybe we can go on to the next
yes, sir.
question.
So Aditya asks if the policy has some architecture in mind. So given its federated architecture, so again, data sharing is a separate issue. We will cover that in a different stakeholder conversation. Here we are focused primarily on storage of the data, right? So the retention of the data. Sorry. Yeah. So this is an interesting question from Pramod again. So the question is, do we have a different retention policy for non-ABDM health facilities vis-a-vis ABDM health facility. So this is a critical question. Pramod sir, your inputs on the same, your thoughts on the same?
I don't think it's going to be pragmatic to have, different retention policy for those who are in ABDM and those who are out of ABDM. I think you'll have correctly pointed out what happens when a hospital goes. See, normally most hospitals, especially in tier 2, tier 3 and rural areas, I would expect would want to be in the ABDM program because that is going to be a lifeline for them. Let's admit it. Okay, it's going to be a lifeline for them. As it is, knowing many of the rural hospitals, they are literally hand to mouth, and the ABDM program is one which is really going to be a life saving for them and have them continuing to serve the community around. Now, the thing is that what happens is they may come into the program with all good intentions, but due to some sort of circumstances, as you know, ABDM program doesn't take the whole hospital. It will only take those departments which are actually made the cut to be within the ABDM program. So it's possible that an entire hospital may come in and next year be out because of some non-compliance, or some department within the hospital would be in and then out the next year because of some non-compliance, and then come in again after they do the compliance. Like you said, imagine a hospital like that trying to, get into the retention rules and whether they should maintain for 10 years, and when they are out, can they maintain for 5 years? It is going to be real confusing. And secondly, it's not very fair also, because then as a patient, when I want to see, I will have to see, okay, this is an ABDM hospital, therefore my records here can be kept for 10 years. Therefore, it is safer for me to go there. In case something goes wrong, I know that, there's some recourse possible for the next 10 years. Oh, that is a non-ABDM hospital. Therefore, if I go there, I do not have any assurance that after 5 years, what will happen in case my records have to be looked up to. So I think both ways, if you look at it, both for the patients as well as for the organizations, it's not very feasible to have this sort of it has to be probably, all or sort of none sort of, pragmatically looking at it, all or none sort of a policy. That's what I think, or I feel. How difficult is it to get the states and the different stakeholders to come on board for that? That's something you'll have to address. Thank you.
A very relevant question. And I think this is also a question that I raised as part of the discussion. And like I said, one can increase their boundaries and end up in trying to create something that might be difficult to eventually enforce. Like I said, this has a lot of enforcement issues. Because if somebody is already in my ABDM ecosystem, I know that there is an audit, I know there is a data protection officer, I know there are guidelines, and I know that I will be able to do certain sanity checks to ensure that things are being followed. But how do I make sure that those who are not also are following? So this needs a lot of a concerted effort by the different agencies. Like you all know, the health services are provided mainly by three ministries at the Government of India level: the Health and Family Welfare, the Ministry of Ayush, and the Department of Women and Child Development. And at the ground level, they are implemented by different state governments. So how do we make sure that we bring all of them onto the onto one single platform and to agree to certain standards and ensure that they are also enforced? That is the challenge. But yes, if we can go for something across the board, nothing like it, that will be probably the best possible scenario. We would definitely try to work for it. But then there also have to be practical considerations of what can be done and what cannot be done, and what can be delivered in the immediate future, and what can be looked out as a long-term future perspective. So I think the final decision would have to take all these factors into consideration. But yes, this is a very live question, and this will always be at the back of our mind when we come up with the final guidelines.
Thank you, sir. So Aditya and Puneet are having some questions on data sharing and anonymization, and whether a patient can opt out. Yes, a patient can choose to opt out whenever she or he chooses to. Okay, Rishabh has asked for an extension, maybe not in December. We will keep it open for a later time, sir. But at this point of time, we have put in a deadline of 1 month since the policy was released. If there are many others who are interested in responding and need some time, we would be happy to consider it at a later point of time. Thank you. Okay, so Sarah was asking if OTC services like nursing, medicines, prescriptions, will all these be included as part of the data retention policy? So we need to figure that out. We will look at, what are the data types in each of these definitions. If you have any inputs over here, Sarah, we'd be happy to hear out. Sarah Raj?
So if the question is about what happens to the data that is what you call let's say a prescription data, or what I get from a pharmacy or something like that. See, that also becomes a part of my medical records, and that also will be part of the overall data retention policy itself. So anything, see, health record or health data is not just something that what a doctor writes for me, a prescription, or what a diagnostic test that I have. It is anything. We are actually talking about the overall well-being or the wellness, the idea of health and wellness. So any data that can determine my health and wellness status at any given point of time will be part of it. And if it is created, managed, stored, or processed by any player, at least currently in the ABDM ecosystem, will be part of the data retention policy. We'll have to we'll have to comply with the data retention policy or guidelines. Back to you, Arun.
Yep. So Pramod's suggesting a different way to store image data because they're really large files. Monica says something interesting, Monica Ban. She says that we should project this in such a way that the patients understand the benefits of data retention as well. So facilities which retain the data are the places where patients will go to, and also this ensures that more facilities will become a part of the system. He talks about incentivization mechanisms. Monica, do you have anything to say beyond what you messaged over here? Please feel free. And Monica, be unmuted, please.
She seems to have left.
Okay, we'll move on. Okay, so a few more questions on consent, but we've covered that as well. Okay, some ideas on how to standardize it through ICD codes. Dr. Santosh Puri, you'd suggested that we have an approach to retain data related to wearables. Do you want to talk about this, Dr. Santosh Puri?
Yeah, sure. Thank you. I think that's in the Western world, if we see, wearables have reached to a next level. And right now we are at very nascent stage in country like India. And in any form, let it be, from preventive health, like sir mentioned about health and wellness. So down the line, 5 to 7 year wellness is something which will be seen as a disruption in Indian market, not only from insurance perspective, but even from preventive health care. That's one part. Second part, we have been talking about standardization of data. So the only recommendation or suggestion from my side is the more we standardize even the variable data, that will be available for participants to frame various incentive mechanisms to preventive healthcare and wellness, which will benefit in long run. So that was the only thought from my side. Yep.
a very relevant suggestion, Dr. Puri. Would you like to elaborate on what you mean by variable data?
Yeah, sure. So variable data, it can be, typically the number of kilometers, number of steps somebody walks, the calorie intake, the sleep pattern.
Variables.
Yeah.
I'm sorry, I was hearing it as variable. I was just wondering. Variables. Okay. No, absolutely relevant, and that is something that we are also actively considering. And when we say we will be going digital, that obviously covers see this kind of data also. The only thing is, how do we bring these players on board, and what kind of what you call incentive they would see in coming on board to the system. But yes, this is definitely a very important part, and I think going ahead, this is going to be the what you call the future, in which we will be capturing most of the vital data of various people, not only those who have long-term conditions, like illness conditions, but also even somebody who would like to actively track his or her health status. Yes, we will definitely have what you call a strategy to bring these players also on board.
Thank you, sir. Finally, one last question on chat from Amarjit Chima. He's questioning why we need this policy in case of HMIS. I don't think I understand the question, sir. Could you elaborate on this, please? Amarjit Chima.
Very good evening. Thank you for giving this opportunity. I'm audible?
Yes, you are.
Okay. So if we talk about the retention, so my submission is that when we talk about retention, so we always come across the medical record department where they have the manual records, the case sheets and lab reports in a paper form. And for this, they have a 5-year for OPD, 10 years for IPD, and medical legal cases in some hospital is permanently they stored. And in some hospital, they have a 10 years or till the cases are active. But in case of HMIS or EMR, we have not received any request for the retention policy. So they always want MRD and hospital to retain these record for lifelong, because this purpose of health record is patient care, medical and allied education, research, legal protection, and administrative planning and control. And as Dr. Pramod has also noted that when we have this storage availability and when we need to analyze these data for long runs for genetic research, and now we are, with the help of epidemia, we are in position to complete the patient electronic medical record, then why we are worried about the retention? Why not we make it as an archival policy that the data should be stay in HMIS or electronic medical record, and if the data is not in use from last 10 years, it should be moved to the archival part, but it should be available for researchers and or any education policymakers who can use this data. So my only question is that why we are putting it as a retention? Why not it's an archival policy in case of HMIS?
Chimaji, thank you for this very, very valid question, which questions the very fundamental idea behind data retention. See, you are absolutely right. And going on what Mr. Pramod Jacob told some time back, that data storage costs are coming down, and we could keep data for so long. Why should it be? Why only 10 years? Why not make it 20, 30, 40, even 100 years? Completely agree. What happens is, if we do not have a policy and we simply say archive it, see, data archiving is what? It is part of data retention. If I say you store data for 100 years, you will only archive it and store it. So I would say data archival becomes effectively a subset of data retention. Data archival is like one specific act of data retention. And it is also true that it may or may not always be necessary to store all data for eternity. And sometimes there was also a very, very, very relevant question about data becoming irrelevant. So the idea is that a data retention policy, if we simply write that, okay, keep this data forever, it's like saying that this belongs to everybody. That means it belongs to nobody. The idea of data retention policy is to what you call try to handle and address cases in a more specific manner. And where necessary, yes, we will definitely be talking about retaining data forever, like we said, the birth registration records or death records or immunization records, etc., etc. So this is only an attempt to classify data and give a kind of guidelines on storage. And if somebody really wants to store it until the end of the world, I mean, I'll be more happy than anyone else. That is like the best, probably the best thing that can happen. And like you said, in HMIS or EMR, data is anyway being stored and nobody is asking us, ye data nikal do, ye data hata do. I mean, it is only the beginning. How many hospitals are using HMIS in this in our country, and how widespread is it, and how effective and how comprehensive is it? That is the question. अगर मुझे सिर्फ OPD records ही store करना था या इनफैक्ट OPD registration ही store करना था, that would not be a major thing. But as data keeps on piling up and as data keeps on adding, I need to have some way of classifying it and some way of dealing different kinds of data in a different way. So archival is definitely a part of it, but I would say archival is a specific part of it, is a subset of it. And it's an eventual thing. What happens after 10 years? You archive the data. What happens after 20 years? You archive the data. So that is what happens after this. But idea of saying data retention is you keep it alive and active for at least these many years. After that, you archive it. You also, I believe, are coming from a technology background. You would understand that if I were to archive the data, just imagine how readily available would it be. So this could be considered as keeping it live and readily available versus archiving it and storing it somewhere to be processed and taken out and not easily retrievable on demand. So when we say data retain X data for 10 years, we say retain data for 10 years to be available on demand. I think this is this should be what you call understood and completely. I mean, archival is going to be what is going to eventually happen. Whereas when we say data should be stored and available, this is how what we intend to do. I think, but I still agree. This is a very, very relevant question, and we will definitely come out with more clarity on this. Chimaji, does that answer your question?
Yeah, sir, agreed, sir. Another, I am having submission that when we are talking about this retention policy, I do agree that we one case we should have, like if somebody don't have any episode in last 10 years, then their data can be not retained, or it could be archived, or it can be removed from main storage to the passive storage. But in some cases like chronic disease, like where the patients having more than 10 years of health records, so such records should be depend on the doctor or on patient side, that they don't want to continue the retention of more than 10 years. So such flexibility, I think, should be with patient or in case of a treating doctor, that they want to continue these such records.
This is a very, very good suggestion. In fact, while I would say that part of it has been attempted in the special classification that we try to say the different category that we have, but this option of additional storage for certain more period is something that we can definitely consider, or this will be definitely discussed, and we will see what would be the best possible way to achieve this.
Right, so thank you very much.
Thank you.
Thank you so much. Unfortunately, I got logged out of my chat midway, so I don't see any other questions. I think I largely covered everything. Rajendra Sharma, though, talks about, what the retention policy should be for minors. So should we retain their data till a particular age, or should we do something else? Sir, your inputs.
Right. I think we try to partly address this when we say that what happens to an individual's data until they turn 18, and after the 18, then when they become an adult, legal adult, then they take a call on how the data is to be dealt with. So the policy or the guidelines in a way try to address it, and if there is any specific input, you're very welcome to share it with us, and that will be very, very helpful for us in framing it even better. Is Sharma ji online?
Thank you. I think this address well, and I just thought to you answered my question actually. Nothing specific other than that.
Thank you.
Thank you. So there's this question from an anonymous attendee. She or he says that retention for more than 10 or until the case is open is required for MLC. I'm not sure I understand what MLC means.
Don't worry, MLC is medical legal cases, and we already have it as a special category where we will store the record for longer durations.
Got it.
I mean, or rather we would say that the guidelines say that such data should be stored for longer durations.
Understood. So I think we've covered all questions. If anyone else would like to say anything, please feel free to raise your hand and we'll call upon them.
Mr. Sharma has something to say.
Just thought something about the disease reporting actually. I know, this is a separate part altogether, but is that something like we mentioned exceptions for birth registers and death registers? So disease reporting also, we have any exceptions?
Okay, see, again, this ultimately there are like two parts to the thing. One is an individual getting a particular disease, and that disease actually becoming a pandemic, like the current case of COVID. It is obvious that we would have to store the knowledge of COVID and the way it affected and how it actually affected populations, so that it adds to our knowledge base. But we would definitely not be interested in storing X got COVID or Y got COVID or what happened. So the idea is the idea is to separate out the personal or the private part of the data and use the knowledge part of the data for future use. That's the idea.
Okay, it makes sense.
Okay, great. So I think we've covered almost all questions and answers. I don't see any other hands up either. So Kiran sir, with your permission, we could possibly end this session.
Yeah, I think if nobody else has any other questions, and I would like to also mention that those of you who have raised your questions on the chat box, we have all recorded all of them, and we will try to answer each one of them and make sure that your question is answered. I mean, please do not feel discouraged that if you had raised a question and we inadvertently missed that is absolutely not our intention to miss any questions or queries. We would be answering all of them. Whatever you have shared with us becomes part of our repository, and it goes a long way in further refining our guidelines and policies. So that is one thing I wanted to emphasize. If the additional CEO sir has anything to say here.
Yeah, nothing to add, Kiran. I think the discussion went on well, and we will now finalize the policy and submit it for approval to competent authority after considering all the feedbacks. Right.
Thank you, sir. Thank you for your time, and I thank everyone, all the participants who've taken out time to join this consultation. And thank you, Arun, for conducting this.
Thank you, everyone. Thank you so much, sir.
Thanks.
Have a good day, guys. Bye-bye.
We can leave.